Good evening, friends. Welcome to the Tuesday's master class of critical care medicine from Yashoda Hospitals in association with the Hyderabad IDCCM critical care chapter. So for this, today the topic of discussion is acute pulmonary thromboembolism. To discuss with, we have our students, Dr. Sindhuja, who is a DRNB student, DRNB student in critical care medicine, and Dr. Shashikiran is IDCCM student at Yashoda Hospital, Secunderabad. For this discussion, we welcome warmly Dr. Farad and Kapadia sir. He is a senior consultant at PD Hinduja and Research Hospital and Research Center. So he's a seasoned and very experienced teacher. When I was in my MD, so I read his book, Farad and Kapadia sir's book in basically ICU protocols and all. So he's a very seasoned teacher and past president of IDCCM, so and chairman and founder president actually. So and I welcome Dr. Manoj Singh sir. He is the senior consultant at Apollo Hospitals, Gandhinagar, Gujarat. So from here we'll take whenever like the presentation goes on the flow, probably you can ask in between sir questions pertaining to that slide and all. So with this, we will start the presentation. Dr. Sindhuja, you can go ahead and proceed with the presentation. Thank you.
Dharmesh, please. Okay, done. Make it full screen. No, I think you have to close and reopen it again. Close the presentation and reopen it again.
Right.
Good evening, everyone.
Yeah, good evening.
And I'm going to present a case of...
Yeah. Can you speak a little louder, please?
Okay. Sir.
Or speak closer to the mic, one of them. Why don't you just start talking till this presentation comes up? Presumably know the case, right?
Yes.
So just go for it. And then when the slide comes up, we can recapitulate.
Now it's coming. 67-year-old female is presented to ER in unresponsive state. The history given by the proxy by her husband.
No, I'm waiting for the slide. Don't stop sharing, but till the slide comes up, let's just at least hear the background spontaneously.
Yes.
Hi, sir. Pawan, you can share the slides, right?
Yeah, one moment, sir. Is it visible, sir?
Yeah, it's visible now.
Yeah. Dr. Sindhu,
please go ahead.
Is it visible? Please go ahead.
The history given by proxy by her husband is like she had complaints of sudden onset of breathlessness of grade 3, 12 hours prior to the event, associated with chest discomfort, relieved with nebulizations and oxygen support and BiPAP support. And
So where did all this occur?
At home, sir.
So they have nebulization and BiPAP and all at home already?
She was using home BiPAP overnight for last 6 months for OSS.
So that means she's already quite unwell.
Yes, sir.
Okay, continue.
And her husband is a RMP, so they have certain instruments at home. Following that, she had similar episode 1 hour prior to the incident, which was not relieved with the oxygenation and nebulization and BiPAP. Then followed by decreasing.
Again, at least I can't see the slides. I don't know what's happening.
Pawan, what happened again? Why it is coming?
They are trying to share from there, sir. I think it has come now. Yes. Continue, ma'am. Go to the slide, second slide.
Yes. She had a similar episode 1 hour prior to the incident.
Can make
which
it
was
the
not
full
relieved
screen.
with the
Sindhuja.
oxygen.
It's okay. It's okay. Let's move on here. We're getting a little stuck. Either way, just whichever way is working, let's move
Next
on.
slide.
Followed by unresponsiveness. Husband did CPR at home and immediately shifted to the hospital with the oxygen
So
support.
when you say she was unresponsive, did she also have a cardiac arrest? Because normally for a person unconscious, you don't start CPR, right?
She was unconscious and not breathing as per her husband's.
Okay.
So he started chest compressions and BiPAP with oxygen support. He shifted it to the hospital.
Okay. Continue.
No history of cough, fever, palpitations, sweating, vomitings, abdominal pain, involuntary movements, or headache.
Okay.
To the past history, she is a known diabetic and hypertensive since 10 years. She was using telmisartan 40 mg OD and the glimepiride and metformin OD. She's
Again, the slides are not actually moving. I'm still on the title slide. Okay. Yeah.
She known case of a CAD on medical management, stopped using antiplatelet since 2 years. And she was using overnight home BiPAP for the last 6 months for obstructive sleep apnea.
When you say known CAD, what does that mean? Did she have a heart attack? Did she have a decreased ejection fraction? Did she had a plasty? What, I mean?
The reports were exactly not available, sir.
Okay, fine. Continue.
History of fever with cough 1 month back. She was hospitalized for 2 days and she received antibiotics, nebulizations, and BiPAP support. And the reports were not available at the time. Coming to the personal history, she is a housewife, does her own work, no family history, not significant, no known drug allergies, no past surgical histories. On evaluation in ER, GCS is E1, M1, V1, pupils bilateral 2 mm sluggishly reacting, carotid pulse is present, heart rate is around 120 per minute, BP is not recordable, temperature 98 degrees Fahrenheit, and respiratory rate around 16 per minute. Cardiovascular system S1, S2 present, respiratory bilateral V's and Krebs are present. On general examination, bilateral pitting pedal edema is there. She's well built. BMI is approximately 33.2. On investigations, GRBS is 362, urine ketones were negative. ECG showed
What does GRBS mean?
random blood sugar levels, sir, at that time.
What does G stand for?
Gross.
Okay, fine. This is the random blood sugar. Okay, continue.
Glucometer based.
Glucometer.
Okay.
And ECG showed sinus tachycardia. Screening echo at the time she had tachycardia during study. Query RA RV dilatation. LV contractility is fair. IVC is 2 centimeter, non-collapsing. ABG showed mixed respiratory.
1 second. At this point, you should be giving. Okay, that's the sugar, right? That's the blood. This is the sugar from the finger puncture.
Glucometers.
Okay, fine. Continue.
ABG showed mixed respiratory and metabolic acidosis, high anemia. pH is 7.13, PCO2 is 56, PO2 is 72.6, and bicarb is 15, lactates were 9, sodium is 136, potassium 3.6, and chloride 102.
This is on BiPAP.
Yes, sir.
Okay.
And blood, urine, and ET cultures were sent after intubation, and CUE is sent, troponin I and D dimer were sent, and planned for CT
So
chest.
I'm unclear. Why was she intubated? That's not clear till now.
She has threatened airway and she is in shock with high metabolic acidosis.
So is shock an indication to intubate someone?
Yes, sir. Severe metabolic acidosis is one of the.
Severe metabolic is an indication to intubate someone, is it?
Yes.
Really?
Low GC is also associated with hemodynamic instability, sir, and which was associated along with metabolic acidosis. So in view of hemodynamic instability and threatened airway, we have intubated.
So when you have a hemodynamic unstable patient, intubate them, does the hemodynamic get stable or get more unstable?
No, sir, it actually helps in taking part of the oxygenation and decreases the work of breathing in case of.
But till now, you've not mentioned either of those. You've not mentioned there was hypoxemia, nor did you mention there was increased work of breathing. This is why I asked you, why is she intubated?
GCS was low, sir. Even V1.
Does every GCS person need to be intubated?
GCS of 3 is a indication for intubation, sir.
Is there any better way to decide whether a person needs to be intubated or not, other than the GCS? Anyone can answer.
ABG is also supportive evidence to intubate. It can decide whether to intubate or not.
But we're talking of an unconscious patient. So one so-called indication is a GCS.
Aspiration.
Is there anything which is more relevant, more specific? I can see some raised hands, but I don't know how to access you also.
Yeah, so the participants can put on the chat box or question answer boxes so that we can access them. But
Yeah, I would personally like to make this as interactive as possible. And if you're getting a little stuck, then I'll hurry it up. Okay.
Yeah, no issues, sir. We can.
So raised hand, can someone, whoever's raised the hand, are you asking a question or are you answering my question? What is the best way to decide whether a person who's unconscious needs intubation? What is the single most important thing to clinically evaluate?
Probably you can.
Yeah, I can see something in the question answer. SS gag, perfect. Right. Okay. So that's the correct answer. The correct answer is it doesn't really matter what the GCS is. It matters how well the airway is protected. Okay. Right. So if you have someone who's got a totally patent airway and has not eaten for some time or this thing, you don't have to rush into intubate. But it sort of goes hand in hand that the lower the GCS is, the higher the chance that the airway is not protected. Okay. So the airway could be obstructed or it could be unprotected. Either of those two is an indication to intubate. And normally it's obstructed airway, which causes intubation, which requires intubation. Can you quickly tell me how you calculate, how you score a GCS? Quick, so we don't waste too much time.
So total score of 15, sir, divided into eye response, motor response, and vocal command following. So spontaneous eye opening.
Your sentence is not complete. One word is missing. Dash motor response, dash eye response. Is it eye response? Which part of the eye are you looking at?
Spontaneous eye openings.
Eye opening. Okay, so that's different from eye.
Eye opening, yeah.
And motor, what? But you're still not saying it right. Or you're not saying it completely.
Motor response.
Someone, I thought I heard the correct answer. Can someone tell me?
Best motor.
Best. Okay.
Best motor.
If one hand is moving and one hand is not moving, you take the hand which is moving. Okay. Right. Okay. So tell me, how do you score?
So eye opening, spontaneous eye opening score of 4. On command it's 3. On painful stimulus it's 2. And no response to no response is scored as 1. And best motor response is spontaneously moving, it's a 6. And
spontaneous movement.
No, obeying commands.
Yeah.
And it's on the following commands. Then painful stimulus. Then whether the patient is having a.
Wait 1 second. 6 is obeying commands, right?
Obeying
Obeying
commands.
Yeah. So then continue after that.
Localizing pain.
5 is localizing pain. 4
Okay.
is withdrawing to the pain.
Painful stimulus.
Yeah.
3 is decorticate.
Decerebrate.
2 is decerebrate. 1 is nil response.
Okay. And
Verbal response, obeying
Vocalizing.
what does vocalizing mean?
He's
Vocalizing
able
can
to
mean
speak-
anything.
He's able to speak words.
Words. You sure?
Oriented to is
But how do you know the patient is oriented? You're checking the verbal response. Right?
replying.
Communicating.
Oriented to.
Okay. So very simple. Constructing sentences, probably lucid sentences is 4.
Proper sentences.
Yeah.
And,
Words is 3. Incomprehensible sounds is 2. And nothing
Inappropriate
is 1.
sound,
Yeah.
incomprehensible sounds. No response.
Okay. So no sound is 1. So just a few grunting sounds is 2.
Inappropriate words, incomprehensible
Yeah.
sounds, and
Yeah. Okay, fine.
Forming sentences.
Right. Okay, continue.
And,
Mm.
next.
So in this lactate, what is your normal range? 2 or 20?
2, sir.
2. So this is high.
Yes.
Okay. So what all conclusions can we make on the basis of this blood gas till now?
So patient having a clinical relevance of shock with denotes impaired perfusion, sir, and having high sugars but ketones negative, but having a high lactates, morely towards a sign of diabetic ketoacidosis, and possibility of high associated anion gap with high lactates associated poisoning substance can also be suspected.
Yeah, but let's stay with the context here. What are we dealing with? We're dealing with a person who's collapsed, right?
Yes, sir. Patient is
We're dealing with a person who's had CPR.
Yeah.
So does the lactate tell us anything useful?
No, sir.
Yeah, I mean, the
CPR
lactate could be
failure.
high because of this current collapse, or the lactate could
Collapse.
be high because of the background disease. We can't say anything at this point.
Yes.
What we can say, for some reason, she's not breathing in efficiently, either because her conscious level is down or she's got some problem in the lung or the airway. Okay. Right. Just a quick, if the bicarb comes down from 25 to 15, how much would we expect the CO2 to compensate roughly?
Change in bicarb is acute conditions 0.1 into change in PaCO2 levels, sir. So,
Yeah. So the PaC has come down by?
10, approximately 11.
So what do we expect the CO2 to be?
11 into 0.1 comes like 1.1.
What would be an appropriate CO2 fall for a bicarb of 15? Again, I don't want stiff formulas. I just want a rough idea so that I know when you look at a gas, you all know this looks single or this looks dual.
A dual, sir, respiratory plus.
No, this is obviously dual. It goes without saying because both have moved in the wrong direction. Okay. Okay, let's move on. I don't want to get stuck here. Okay.
She was intubated and mechanically ventilated. Post-intubation, she had asystole, revived with 1 cycle of CPR, and she received IV fluids of normal saline 300 ml stat followed by 40 ml per hour. Started a noradrenaline infusion and injection Magnex code 1.5 gram IV stat and injection hydrocot 100 mg IV stat was given. Nebulization with Duolin and Budicort were given and started an actrapid infusion.
Okay. Now, what's our differential diagnosis till this point?
Sir, patient coming in an unresponsive state with history of chest pain and
Don't just give me a list of differential diagnosis, nothing else.
so could be a MI, sir.
MI, this is the way an MI presents, is it?
Chest pain with dyspnea with collapse.
Okay, fine. Right, continue.
Pulmonary embolism could be a spontaneous pneumothorax. Could be a
The story really sounds to you like a spontaneous pneumothorax.
could just as a differential diagnosis. Sir.
Yeah, but when you give differential, start with what is likely to be and then put the less likely ones low on the list.
Okay.
It looks most likely ACS bar PT.
And this is a lady who's got oxygen and BiPAP at home, right?
Yes, sir.
Yes.
What does that tell you?
Obstructive aspiration could be.
There is some background lung problem, right?
Yes, sir.
Yes.
So probably whatever that lung problem is has worsened, right?
Yes, sir.
So what would be the commonest cause of a worsening of a lung problem?
Aspiration or pneumonia, sir. Suspected pneumonia, because background history also shows a history of pneumonia.
She was unwell before she had a CPR, right?
Yes, sir.
So why would you think of aspiration? That time she was conscious.
Possible precipitating infections can also.
Correct. Infection in COPD would be by far, I mean, listening to this story, you think that she's a patient with COPD, if she's got BiPAP and nebulizers and so on, and oxygen at home, and then she was getting worse, so she probably got a chest infection. So that should be very high on this thing. And then someone said pulmonary embolism, right?
Yes.
So in your treatment, where is the treatment of pulmonary embolism? You've treated COPD, you've treated an infection, you've treated other stuff. Why have you not treated as embolism if it's that your diagnosis?
Sir, actually the patient's clinical suspicion of embolism is very high, sir. So if we wanted to evaluate the patient by taking her to a CTPA, but because of hemodynamic instability, we have not we have done it later, sir. It's
Okay. Fair enough. But there's a sort of saying that most of us have been trained to think when you have a breathless patient, think oxygen, think classics, think bronchodilators, think steroids, but also think first dose of heparin. Okay. Make it a point to think that all the time. Because the first dose of heparin is really not going to harm someone unless there's a high bleeding risk. Okay. Continue.
Patient was shifted to ICU on noradrenaline 16 ml per hour support with a
What is 16 ml an hour? That's not, it doesn't make any sense to a presenter. How much in how much?
12 mg in 50 ml NS.
Okay.
Saturation is 88%, peripheries are cool, urine output is 20 ml per hour from the ER.
Just go back to the blood gas.
Yes.
Is this saturation matching this PO2?
No, sir.
Okay, continue. Let's go back. Let's move forward then.
She has cool peripheries, so saturation might not be pulse oximeter mein saturation might not be accurate.
Yeah, but normally you get an unreliable reading. You don't get a low reading.
Yes.
Okay, continue.
On day 1, she regained consciousness after shifting to the ICU. She was E4, VT, M6, moving all
No,
four.
when was she obeying commands?
Yes, sir. Obeying commands, sir. Moving all four limbs with power of 5/5.
But she was obeying commands.
Yes, sir.
So she's regained consciousness.
Yes.
Okay, all of you all should just keep in mind, once a person is regained consciousness, the GCS becomes slightly meaningless. Okay.
Yes.
The GCS is there to look at if there is a conscious problem. If there's no conscious problem, scoring the GCS makes no sense.
Yes.
Okay, continue.
She
So
was
this is the single most important thing, right? If a person has a CPR, everything now depends on first has the person recovered consciousness. Did you all cool this patient post CPR?
No, sir.
Why not? Because the patient regained consciousness. That's the answer, right?
Yes.
You cool people who are continue to be unconscious. Right, continue.
She was on ventilator, volume control mode of FiO2 0.4 and PEEP6 and respiratory rate of 20 per minute. She was maintaining BP of 110/60 on noradrenaline.
What is the tidal volume? You haven't told us that.
450 ml.
Where is it written?
I haven't written.
Okay, fine. Continue.
On noradrenaline 15 ml per hour with 12 mg in 50 ml NS infusion and heart rate of 110 per minute, saturation of 94% on FiO2 0.4. Urine output is around 20 to 30 ml. After giving Ditor, it improved.
Well, why did you give Ditor? For what reason?
She has pedal edema, sir. IVC was.
So is pedal edema a life-threatening event?
No, sir.
You want to give Ditor for pedal edema in the middle of this crisis? Did she look like she had pulmonary edema?
She has Krebs, sir, bilateral Krebs, but X-ray was not looking like pulmonary edema. X-ray was.
So again, this Ditor is probably unindicated or unneeded and potentially harmful in a person who's hypotensive. Okay. You should have at least in the middle of a crisis, you should have a very clear reason to give Lasix. And there's only one of two reasons, anuria or severe pulmonary edema. Others, there's no rush to give a diuretic. Okay. Once you got your whole situation sorted out, then you can think about what you're going to give later. Okay, continue.
ECG showed sinus tachycardia, troponin was negative. 2D echo showed dilated ARIA-RV, RV dysfunction with tricuspid annular plane systolic motion was 1.1 centimeter, moderate to severe PAH, right ventricular systolic pressure of 70.
Is moderate to severe PH a sign of acute pulmonary embolism?
Yes.
Yes. Anyone else?
Patient has no history of any pulmonary arterial hypertension, sir, but a sudden onset of increased pulmonary arterial hypertension could be a sign of pulmonary embolism.
Yeah, but listen to my question clearly. Is severe pulmonary hypertension a common finding in acute pulmonary embolism? That's my question.
A massive pulmonary embolism, which with a large obstruction of the pulmonary vein, so it can cause a rise in hypertension or pulmonary hypertension.
How much? Mild, moderate, or severe?
Severe, sir, more than up to 70% obstruction.
Okay, that's the wrong answer. It takes some time for the RV to become hypertrophy to be able to generate high pressures. So if you have a very high pulmonary artery pressure, you assume that something has happened chronically earlier and then something else happened on top. Okay, even a life-threatening acute P in a previously normal RV and a normal lung is unlikely to raise the pressure so much. The patient will have a cardiovascular collapse before the pressure can go up so much. Okay, so putting everything together, this person almost certainly has some prior copulmonal, and that makes diagnosis very difficult. RA-RV dilatation is very useful if you know that the RA-RV was normal before and the pulmonary artery pressure was normal before, and you know the lung was normal before. But in the presence of a chronic illness, it's difficult to say if this is representing the chronic illness or this is representing a new pulmonary emboli. Both remain this thing. Continue.
She had previous OSA component, that might be also the reason for pulmonary
Yeah.
concentric LVH, fair LV function, EF is 56%, no clots, minimal PE, IVC is 1.9 into 1.6 centimeters, hazy appearance noted in the IVC.
So if the IVC is not collapsing, can we be certain that the patient's adequately volume filled?
No, sir, in RV dysfunction, IVC
Excellent.
is not
Good.
active.
That's the answer. Not in RV. Yeah. Okay. Any problem with the RV, even pulmonary artery pressure being high, the RV will anyway be distended, even in a hypovolemic person. Good.
ABG showed mixed respiratory and metabolic acidosis.
Oh my
with
God, this patient is getting worse, not better. You are not ventilating this person properly.
ABG showed pH of 6.9, PCO2 was 105.
When was this? When was this? How much time after ventilation?
After 4 hours, sir,
No, this is really
from
quite
the
bad.
ER.
Okay, continue.
Lactates are 7.5, anion gap is 9.8. Blood reports.
Go back on the slide.
Blood report showed rise TLC of 14,790, INR is 1.08, and creatinine is 0.8, and LFTs were normal.
What is that, the BUN which is 23 or the urea which is 23?
Blood urea.
So that's normal. Sure, na? It's not the BUN.
Yes, so blood urea.
Okay, fine. Continue.
BUN is 28. No, sir, it's blood urea, sir.
Okay.
D-dimer is 3,743, sir.
What's the upper range?
For her, age into 10 comes like 670, sir.
Okay,
Age
so 500 is your upper, plus then
500.
age modified, right? Okay, continue.
Repeat troponin I showed increase in the troponin I from 0.03 to 0.87, sir. At this point, we had high suspicion of PTE, so we are planned for CTPA, sir.
Okay.
CTPA showed.
Next slide.
Did you all do a Doppler?
Compression ultrasound we did, sir.
Yes,
Yeah.
It showed negative for DVT, sir. Compression was present.
We have done
Okay.
a which did not show any deep vein thrombosis.
Right.
Ongoing treatment is Magnex for 1.5 gram BD, nebulizations with duolin and budicort, and thiamine 100 mg IV OD, solumetrol 40 mg BD, and heparin 5,000 units QID given, and IV fluids.
What is the thiamine given for?
She had lactic acidosis and
Is
shock.
thiamine a treatment of lactic acidosis?
No, shock.
Is thiamine a treatment of shock? No, you'll just give it to everyone. That's why it's given, because I don't see any context for thiamine in this clinical context.
In lactic acidosis, we can give thiamine.
No, you can give anything you want, but what's the connection?
It acts as a cofactor. Thiamine pyrophosphate acts as cofactor for pyruvate dehydrogenase. So it
Do you think this is a hypoxic lactic acidosis or a metabolic lactic acidosis?
It is metabolic lactic acidosis.
No, metabolic means in the absence of tissue hypoxemia, this lactic acidosis occurred. That's what you're saying. Or in the presence of tissue hypoxia.
Both, sir.
How can you possibly say that? I mean, in this, you have to automate. A non-hypoxic tissue lactic acidosis is exceedingly rare. You get it some with ART drugs, you get it with linezolid, you get it with metformin, it's not a common thing at all. In this context, I mean, I would be very unimpressed if I was your examiner and you come up with this kind of answer. I mean, this patient is shouting, my cells are not getting enough oxygen, that's why I'm generating lactate. Okay, and the lactate is protective. Okay, or lactate per se is not protective. The lactate is a marker of a energy pathway which is excessively activated because the oxygen delivering pathway is not working. Okay, so anyway, I'm not sure why the thiamine was given here. And the steroids were given for what?
She had persistent wheeze. So
Okay, fine. Continue.
next. CTPA was done, suggestive of pulmonary thromboembolism involving bifurcation of the main pulmonary artery extending into the right main and left main pulmonary arteries and its segmental branches, and left minimal pleural effusion with passive basal atelectasis and bilateral ground glass opacities were seen. So thrombolized with injection tenecteplase 40 mg IV stats.
Is that the correct dose?
According to her weight of 80 kgs, it's coming 40 mg.
Okay, fine. Continue.
Day 2, she was conscious, afebrile on mechanical.
No, you haven't told me where we are with the noradrenaline. Still on or off? Okay, it's still on. Right.
Still on noradrenaline, sir.
So after the thrombolysis, the BP didn't come up.
Noradrenaline support
Requirement has come down.
has come down, sir, compared to previous.
Continue.
She is on ventilator support of FiO2 0.3 and PEEP6 tidal volume of 450 ml per 450 ml.
She's fully conscious right now.
Yes,
Yes.
sir.
And you'll still want to continue volume control ventilation. Any particular reason not to switch to a spontaneous mode?
She was hemodynamically unstable and she had persistent wheeze also, sir.
So is pressure support more hemodynamically unstable than volume control, or it makes no difference? Okay, now this is a really, there's nothing very hard and fast, but over 10-20 years, the trend has been use minimal sedation and use maximum spontaneous breathing, because you allow the weaning to occur faster, you prevent diaphragmatic atrophy, etc., etc. So if you, as you're getting a stabilizing patient in terms of consciousness and breathing pattern, moving to some sort of spontaneous mode may allow the weaning to occur faster. Obviously, you don't overload the system. You make sure that the rate is fine, the volume is fine, the FiO2 PF ratio is fine. Anyway, continue.
ABG showed metabolic acidosis with pH of 7.17 and 39 PCO2, PO2 of 270 and bicarb of 14 with
What's the FiO2?
FiO2 0.3, sir.
Do we have a lot of time? Can I ask you some basic questions?
Bharat sir, if I may interrupt just 1 minute, sir. Dr. Manoj Singh sir joined us as
Yeah.
So
Yes,
welcome,
Parag,
Manoj Singh,
sir. This is an exam type, yes, sir. It goes beyond 1.5 hours, sir. So every question should be asked, sir. It's you are free to openly ask the questions and take some time, sir.
Okay. What is the maximum PaO2 you can get with a FiO2 of 30%? Let's start. What's the maximum PaO2 you can get with a FiO2 of 20% or room air?
100, 110,
Yeah, 30%.
35, 150.
How did we get 270 here then?
It must be a mistake from my side, sir.
No, why would you make a
I had
mistake?
typed it wrongly.
No, the commonest thing is that the patient got a nebulizer before the blood gas was collected. So the patient was getting a higher FiO2 than that what was set on the ventilator.
Yes.
Okay.
That could be the reason.
So Dr. Manoj, can you come on board?
Yeah, I'm on board. Yeah, I'm on board. Venkat.
Yeah. So
Hi, Dr. Farad.
Hi.
welcome, sir.
Yeah, continue.
Lactates 2.9 and potassium is 5.2. There was a rise in serum creatinine from 0.8 to 2. And platelet count is 1.5 lakhs and total counts were 27,000. And there is a rise in SGOT and SGPT to 517 and 471. And ongoing treatment was Magnex-4, injection doxycycline, nebulization with Duolin, Budicart, heparin, 2,500 units QID.
Why aren't you using a heparin infusion till now? I'm not very clear because I've seen this right from throughout. Why aren't you using low molecular weight heparin or heparin infusion?
Sir, actually, because we planned a procedure thrombolysis, we didn't go for a low molecular weight heparin, sir. Continued with heparin and infusion.
But now the thrombolysis is already done, na?
Yes, sir. So.
And again, my question is not why. I mean, there are two questions here. Why are you using unfractionated heparin versus low molecular weight? There's no big deal. They're roughly the same, but it's just much more convenient to use low molecular. And why are you giving it subcut in boluses instead of as an infusion? I mean, the normal conventional teaching is to give an infusion and keep the PTT at whatever 2 to 3 times the upper limit, somewhere between 70 and 80. Have you all been monitoring the PTT on unfractionated heparin?
Yes, sir. APTT 6 hourly done, sir.
And what was it roughly?
It came around 32 only, sir. After
Yes, you're
the
not really
initial-
achieving anticoagulation. And this is the problem when you give boluses, the APTT will depend on what time the last bolus was given. So, and why are you giving NAC? For what reason?
Post contrast, she had rise in creatinine.
Okay, fine.
Suspect
So-
and
So, I
contrast.
mean, frankly, NAC is gone, and post contrast, it's even gone further. So, if at all, peri contrast. And once you give the hydration adequate, then the rest is all probably not necessarily. Okay. And bicarb you're giving for what reason?
Metabolic acidosis was there, sir, with pH of 7.1 and bicarb was bicarb of 14.
Okay, this is sort of plus minus indication. Fair enough. The severe acidosis and inotropes is a reasonable indication. Continue.
Oh, can I ask you a question,
Yeah,
Dr.
sure.
Sudhoja?
Yes, sir.
Yeah, so is the ABG appropriate? I'll ask you again the same question
That
Dr. Farad asked.
PO2 was
No, apart from PO2, how do you say the ABG is appropriate? Is there a machinery error? What is the equation you will use when you say whether this is not a lab error?
will calculate PCO2.
How do you know that ABG was intact? Or it's just a machinery error? One reason
PCO2 upon bicarb into 24.
Correlation of bicarb with the PCO2, sir.
Okay. And are you not worried that even after thrombolysis, the patient is needing noradrenaline, acidotic? Are you not worried on day 2? Can you summarize? Because I think, are you treating a patient of COPD who gets a pulmonary embolism? What is your diagnosis? You are on day 2. I joined late. Sorry for the emergency which I was stuck in. Can you summarize on day 2? What will you discuss with the attenders? Where are we?
There could be underlying lung problem along with the PTE, sir.
Underlying lung problem. Okay. Now, what are the things which come to your mind? You already have a CT, right?
Huh,
Yes.
yes, sir.
So did CT show something in the lung parenchyma as well, or it was only a vascular pathology?
Showed GGOs as well as atelectasis, sir.
So what are we dealing with? Means you got just a Doppler here. It's an elderly patient. Or can I ask you in the other way? What are the causes of pulmonary embolism?
So causes of pulmonary embolism, patient who is bedridden for more than 3 days or on oral contraceptives and history of malignancy or previous history of pulmonary thromboembolism and any hereditary thrombophilias or any previous surgeries, or she's hospitalized in the last for more than 3 days in an ICU. And
Any condition which affects the Virchow triad like endothelial injury, stasis, and hypercoagulability
Surgery
can
also.
predispose to pulmonary thromboembolism, thrombosis and embolism.
But here, as you see, the patient had only a medical history of 1 month back, right?
yes,
Yes.
Since 1 month, you have just produced a history that she has an episode just 1 hour back. So what comes in your mind, which is more clinically relevant here?
PT.
And a cause of PT. Any other cause of PT?
PT.
so she's obese female lady with comorbidities with history of hospitalization and bedridden state and reduced mobility and
Okay.
not taken appropriate medications also, uncontrolled diabetes. So
you're not too sure. Okay, and you also have mentioned in previous slide that she was a CAD patient, not pulmonary. So there was a vasculopathy angle, right?
yes,
Yes.
Can malignancy produce like this?
yes, sir. Undiagnosed malignancy is sometimes present as pulmonism also.
So how will you counsel attendants? What are we dealing with? still in shock. And as Dr. Farad rightly pointed out, there is no point of actually giving heparin intermittently because you're not having a predictable hepatity, there.
Yes.
So how will you counsel the attenders?
Sir, initially, once communicate to the patient so that, but that we have done the main suspicion of thrombolysis was pulmonary thromboembolism, which was thrombolized. And after thrombolysis, there was a decrease in the vasopressor support as well, not completely, but decreased in vasopressor support as well as oxygen support. And the CT simultaneously showing infective pathology with having patient is also having uncontrolled blood sugars. In view of her background history of CAD and correlation with an echo, having RV dysfunction also, and underlying CAD, she requires a prolonged hospital stay and needs a and need time anticoagulation therapy should be continued. And once she's hemodynamically stable, then we can plan for an extubation. Further, as the course goes on. Okay.
Was there an echo on day 2 done?
Yes, sir. It showed actually continuous RV dysfunction was there, sir. Persisting RV dysfunction was there.
So do you call this as a failed thrombolysis?
There was immediate RV dysfunction might not be improving in all the cases, sir. But there is decrease in the noradrenaline support. So I think we can wait on anticoagulation. There is persisting high noradrenaline support. We might have to go for a mechanical thrombectomy.
Immediate improvement in hemodynamics are not expected as such, but I think patient hemodynamic vasopressors improvement requirement has come down as well as oxygenation. So if there's a positive side of the thrombolysis.
Okay, I think we'll go ahead to the next slide.
Day 3, she was obeying commands, febrile on volume control mode, FiO2 of 0.4 and PEEP6, and persisting V's on noradrenaline 5 ml per hour and urine output of 50 ml per hour. And ABG showed respiratory acidosis 7.27 of pH, and PCO2 was of 55, PO2 of 75, and bicarb of 25 with lactates of 1.25. Blood sugars were under control, and ultrasound abdomen was done, bilateral grade 1 renal parenchymal disease, and minimal left pleural effusion and mild hepatomegaly and mild ascites was present. Ongoing treatment was meropenem, doxycycline, nebulizations, and hydrocort and Lasix infusion 5 mg per hour.
Again, why was the antibiotics escalated? For what reason?
Sir, shock was still persisting. So, even after initial antibiotic therapy,
is that a reason to escalate?
There was increase in total counts also. Could be infective part might not be in the control. So,
very
antibiotics were escalated.
Why is this person still on a Lasix infusion? I'm unclear again.
Negative balance. RV dysfunction.
You got a person in shock, you want to have a negative balance.
No, sir. Respiratory side, she had persistent V's and reps. So
Lasix is a treatment for persistent V's, is it?
No, sir.
My feeling is a lot of the things which have been done here are just done out of habit and not really individualized to the patient.
I agree. And also, Bacho, you should actually treat only one disease in one patient. You are trying to treat so many things together. So you will actually lose the focus of the outcome-directed therapies. Just leukocytosis should not trigger you to increase the antibiotics. And so is the wheeze, because she's been wheezing since the day you put on ventilator, and probably there is a past history of OAD. OAD patient will also sound wheezing all the time. And wheeze is not pulmonary, right?
Yes.
Okay, let's move on. So so she got AF and was given amiodarone. Continue. Okay. I'm a little unclear why the CO2 is jumping all over the place like this. You got a 75, then you got a 100, then you got a 40, now you got a 55. So is there ventilator dysynchrony or what? I mean, the earlier blood gas had a respiratory acidosis. Now you're back to first you had a mixed acidosis, then you had a respiratory acidosis, metabolic, and now you got a respiratory. And the lactate is normalized, right? So generally, lactate normalizing means you're doing a good job. The patient is getting better. Okay, continue. At what point would you consider weaning this patient or at least trying a spontaneous mode?
The next day, we tried spontaneous and extubated her, sir, day 4.
Yeah, but my question is, at what point will you consider moving from a control to a spontaneous mode?
When the underlying pathology has resolved, so in her case, improved.
That's the time for weaning. You can move to a spontaneous mode much earlier than that. Remember, try to keep patients breathing by themselves with the support. A pressure support allows the patient to have some control over their own breathing pattern, while a volume control, the patient loses all control over the breathing pattern, and it allows the diaphragm to be somewhat used. So if you're getting a recovering patient, the trend over the last decade or so is use less and less sedation, keep the person more and more awake, and try to keep the breathing more and more spontaneous. Okay. Okay, continue.
Day 4, she is off vasopressor support, maintaining BP of 120/60, AF with control ventricular rate, and urine output of 80 to 100 ml per hour, and ABG shows.
Are we off the diet drip now or not?
Off.
Yeah, we are giving intermittent BD Lasix, as you see.
Okay, that's okay. That's chalega, but right. We are off vasopressor, so everything is going well, right?
Yes, sir.
ABG, so now everything is settled. Okay. Quadron.
Bit.
So the quadron is going down the nasogastric tube.
Yes.
Yes.
Okay. And why was the beta lock added?
Metoprolol for AF only, sir, they have.
But the quadron wasn't controlling it.
No, sir. Initially, cardron was
Okay,
the
fine. And why we switched from heparin to fondaparinux?
one side dose.
Wow.
There was a
Early-
relative decrease in platelet count, sir, compared to admission.
Okay, this is all very soft stuff. Yeah, keep going forward. I mean, normally this patient should be well anticoagulated. Continue. Yeah, continue.
Next.
Slide.
Day 5, she was extubated on nasal prongs of 2 liters, maintaining saturation of 94% and off vasopressors. Continue to have AF with a controlled ventricular rate and urine output of 80 ml per hour. Next day, she was shifted to step down and discharged on day 8.
Very good. Well done. Good job. Any further slides?
No, sir.
No, sir.
Okay,
I'll ask you the same question. What was the cause of PE? Why this patient? So you have discharged within a week, it's a tremendous job actually. But what is the risk of recurrence and what was your discharge anticoagulation advice?
Discharge anticoagulation advice, she was discharged with fondaparinux 7.5 mg subcutaneous OD, sir.
Okay, what was her weight?
80 kg, sir.
80 kg. And what was the cause of PE?
One could be DVT, which might not be.
yeah, but DVT-P is the same disease, just two parts of the spectrum. But they will have an underlying cause, right?
So that means it was not evaluated. Is that what you say?
Multiple precipitating factors were there,
Risk
sir.
factors were
Actually,
multiple, sir.
his diabetic, hypertensive, coronary artery disease was there, obesity, and she was not actively moving also.
Stop medication,
Yeah.
history of hospitalization, and
Respirating infection factor is
Infection.
also.
Okay, I can see a lot of hands and etc. Can any questions or anything will?
I will, yeah. So yeah, there is Dr. Junaid, who's actually, he said the appropriateness of ABG should be tested by the Henderson-Hasselbalch. I agree, Junaid. And he is saying that infection, as what these guys said, could have been one of the cause for PE. What if this patient was a young lady, 25-year-old, presenting with cardiogenic shock secondary to PE, what would have been evaluated? Just I want a theoretical answer from both of you or either one of you. What are the causes of PE in young age?
Oral contraceptives.
Oral contraceptive use.
No, unmarried, yeah, 25 years old.
Hereditary disorders.
Like
Hypercoagulable disorders like
Factor V latent mutation or antithrombin deficiency or any anti-cardiolipin antibody associated disease.
APLA
hmm.
could be also, and protein C and S deficiencies.
And
Anything else? Yeah.
hematological disorder like essential thrombocytosis and inflammatory bowel disease in an active stage, active phase. Could be a precipitated.
Could this patient be, this is the same patient be on steroids for COPD and cause thrombosis? You said she was diagnosed with OAD. Can steroids precipitate thrombosis? There was a lot of hue and crying in COVID times, you remember?
Yes.
Steroids going on from the thrombotic milieu. Okay, what are the class 1 indications to thrombolyze? Tell us. And what are the drugs approved?
Class 1 indications are a patient having a diagnosed pulmonary artery thrombosis with hemodynamic instability and having no other bleeding tendency to be ruled out, and drugs are approved are alteplase, tenecteplase, and retiplase.
That means streptokinase has been disproved, is it?
Streptokinase
No, not approved now.
not used now.
Uro and
Now
streptokinase is
It may not be used.
Used now,
It's
yeah.
still used. It is still approved. It may not be used, maybe out of fashion. Maybe, I don't know. Dr. Farad, are you using streptokinase?
No, I think now it's all boluses and this thing. Because streptokinase has to go as a 12-hour infusion, so the effectiveness is much lower.
Yes.
So for that reason, it's gone because we have drugs which can be given faster and therefore hopefully act faster.
Other class 1 indication where you may have a hemodynamically stable patient. What do the latest guidelines say?
Patient having submassive PTE with progression towards hemodynamic instability, or patient having a RV clot in transit, sir. Or
Clot in transit means what?
having
On
a
the
clot
way.
in the right ventricle.
No, will you thrombolize that? Will you thrombolize a
If
moving clot?
if there is progression of the symptoms, sir. If the patient being stable, then gradually progressing into an unstable.
No. See, you divide patient class into 3 categories. One is clinically what you're trying to say again and again. Second is echo. Third is the markers. What markers will help you do that?
troponin and NT-proBNP will help. Rise in troponin and NT-proBNP.
Is there any
RBP
classification? Is there
function.
any classification of patients who come to you like this?
Yes,
Where
sir.
you will stage P, acute P.
Hemodynamically stable, unstable, and so hemodynamically stable patients usually they are asymptomatic. So this is one class, and the second class is intermediate class, intermediate with mild risk and high risk. Mild patient having no hemodynamic instability, but having RV dysfunction with positive markers is high intermediate risk. Patient having an RV dysfunction without markers positive or any one marker positive is a low risk. And patient having a PTE with RV dysfunction with positive markers and hemodynamic instability is a massive
High risk.
And stable.
Okay. What are the other therapeutic modalities apart from thrombolysis, which are available in India and one should consider if the other one is not available / contraindicated?
Sir, if there is primary is thrombolysis, sir. If there is any contraindication for thrombolysis, we go for a mechanical thrombectomy, sir. And catheter guided devices, and other is surgical pulmonary embolectomy also. Surgical embolectomy is also another options.
What types of catheter? Any idea? What types of catheter are available?
Which
is the route adopted, and what are these? Are there any studies to support it? Any idea?
Sir, ultrasound.
Ultima trial.
Ultima and CRT 2 trial after 2 trials.
Ultrasound guided catheter directed thrombolysis has efficiency over anticoagulation alone, sir. There is Seattle trial for low dose fibrinolysis directly given over through the catheter over the thrombus. And perfect trial is also there, sir. Catheter directed thrombolysis and fragmentectomy and embolectomy would show efficacies.
And what will be the duration of anticoagulation here? Probably you try to tell us that it is a provoked PE. Correct. So we said that it is an infection causing PE. What will be the duration of anticoagulation?
Minimum of 3 months, sir, can be extended up to 6 to 12 months. Again, the patient needs to be evaluated in whether the patient is having any further symptoms and based on that, whether to continue the anticoagulation or not. And then if the patient is having an unprovoked DVT, then need to continue the anticoagulation for longer times.
Related to cancer?
Patient is having recurrent
an active cancer, solid organ cancer, and PE.
Indefinite therapies.
Indefinite therapy. Okay. What are the drugs approved, and what was this patient given apart from when they came back from in the OPD? Any idea? Any follow-up?
No.
After Fondaret, what was the drug which switched over?
No idea.
No. What drugs approved, or what will you generally consider?
Directly acting oral anticoagulants are preferred in a OPD basis, sir. They usually act through inhibition of factor 10A. Apixaban, rivaroxaban, edoxaban, and dabigatran. Dabigatran is a indirect antithrombin mediated factor 10 inhibitor. And the apixaban dose is given as 10 mg initially for 10 minutes, then de-escalated to 5 mg, sir. Rivaroxaban is given as 15 mg for 21 days, followed by 10 mg BD. And
other way around. 15 mg BD for 3 weeks, followed by 20 mg OD.
And edoxaban and dabigatran require bridging along with heparin, sir. And edoxaban given as 60 mg OD, sir. And
dabigatran 150 mg BD.
And rivaroxaban and apixaban need not have a bridging with heparin. And all these drugs are contraindicated in renal failure. I mean, to be monitored in case of renal failure.
What about the patient was already on dual antiplatelet therapy before, because the patient was CAD, right? You said the patient was CAD. She defaulted, but now you would emphasize that the patient should be on one of the antiplatelets. What will be your change of medication on discharge? 67-year-old lady.
Aspirin can be added to her therapy, sir. And in one study, it is shown that aspirin is beneficial for prevention of DVT, but yes.
Is aspirin with the Novak?
Yeah.
Okay. Dr. Farad, what do you?
Just trying to ask some questions related to PE in general. I think we've mostly covered it. So the grading you all have covered. The indication for thrombolysis you have covered. I mean, you're right. I just want to say we wrote the DVT guidelines and we had a lot of difficulty publishing it because there was a lot of disagreement.
Yeah. I think India needs one local tailor-made guidelines.
But the problem with the DVT guidelines from the beginning to the end is they've been based on diagnosing PEs on DVTs on Dopplers. They've not been diagnosed. They've not been given in the context of actually improving patient outcomes. So that does need, almost all the DVT so-called hard guidelines are not based on improved clinical outcomes. As of now, there's no trial which is randomized, which says that even in massive PE, thrombolysis actually improves outcomes. It's based on observational studies.
True.
And we had taken part in a study called the LifeNox study, which high-risk patients were given just heparin, one OD dose of, in a randomized trial, and it made no difference to any clinical outcomes. So there's a lot of gap between demonstrating decreased DVTs with Doppler compared to demonstrating improved clinical outcomes in terms of whatever mortality, hospitalization. So it's a treatment we continue to give, but we should have an open mind that as of now, we're treating a surrogate marker more than we're treating outcomes.
Yeah.
Will we get better data? We'll continue doing what
Mm,
we continue doing. I'm a bit surprised this patient went on Fondaparin-X.
Yeah.
We have switched to an oral
Yeah.
one. It's
Yeah.
just this inconvenient, and there has to be some sort of long-term strategy here.
In fact, to add to one of the clinical markers, because I do pulmonary as well, the centers which are doing the CTEF surgery, which is not our topic of interest, actually they started switching to Novax, but they had a very bad failure post-operatively. So they are still with warfarin and acetrom, you know. So to them, the older and the conventional anticoagulants work better. So I do not know, because as you rightly said, the outcome does not change, because nowadays we are a habit of having Novax immediately after discharge, and the long-term repeat CT pulmonary angio no one is doing. And probably the patient are followed up with their primary physicians, you know.
Yeah,
And
but whatever
as you
data
rightly
is shown
said-
is that the Novax are slightly better, both in terms of recurrence and in terms of bleeding.
I agree, but we
So
don't have a data for that from India. So I'm talking about, so I have a lot of patients who continue to follow with me only because I've seen the change in the prescription, you know, since the Novax have come almost 6 years from now. They are definitely effective, but when the patient doesn't improve this, and again, the patients living in the city don't have a problem monitoring INR, you know. So we definitely, for patients who had a thrombus load very severe and sort of provoked, and the primary cause not going to reverse, we have a habit of, you know, because they're going to be on lifelong, we have a habit of just continuing them on acetrom only, you know. Like our cardiac surgeon, you will agree, the patients on valve disease.
No,
acetrom
valve is
for
black and
years,
white.
you know.
Valve is
Yeah,
black
yeah.
and white. Valve is warfarin, but in the
That's
absence
the-
of valve,
yeah.
I don't think there's any other medical indication where warfarin is demonstrably better.
No, it's not
So
better.
I mean,
just I'm
even
trying to tell you that
couple of
what the
years back, I
centers-
would have done
Yeah.
this, but now I give
Yeah.
all the patients the choice. The prices have come down a lot.
Yes, yes.
Most
that
have
is true.
over the years just moved to these.
True.
And I can't remember a new patient being on warfarin straight away. I mean, everyone is, the price of, they've all come down a lot. Okay.
IVC filter has not been discussed. I think if you
Yeah.
want to ask something about IVC filter.
Yeah, there was one in this thing. Anyone
Yeah,
wants to
chat box.
comment? One of you all want to comment? IVC filter?
IVC filters at present are not used preferably, and if they are used, if there is any contraindication for anticoagulation or patient is having recurrent embolism or DVT in spite of anticoagulation, we use it. It can be a permanent measure or a temporary measure also. IVC filter.
Yeah, but the latest guidelines say there's no role for it in prophylaxis. Only you have to tailor it to a given problem. Okay. So person has a large load and has recurrent and is on anticoagulation or is due for a procedure. But the role of a prophylactic is disproved in a double-blind RCT. So there's no role. Just let's hope that we prevent the next clot. It has to be individualized to a specific clinical situation.
And more so nowadays, the retrievables were more commonly used.
Yeah.
So,
But again, they're used at least the ones we use is in the context of a procedure. So you put the thing, do the procedure, let the patient get
And
better
come
and take it out. So in the absence of that, it's difficult to know when to use a retrievable.
So what is the role of pericardiac arrest thrombolysis? Sir? Some patients who are very high risk, you suspect very high risk at pulmonary embolism, patient had a cardiac arrest, you are doing the CPR. So there are some articles where they say like what is the role of peri-arrest?
What is the role of?
Pericardiac arrest thrombolysis in patients.
So we have done it actually in last 2 patients actually going in the OT. During the OT, they had an arrest and it was proven that it is related to PE only. We have thrombolized the patient.
You're talking of intrapulmonary artery thrombolysis.
Yeah, peri-CPR means like how AHA has updated the guideline 2020. During peri-CPR, it's an obstructive shock of cause of cardiac arrest leading to this massacre actually. So the thrombolysis is class 1 indication. We've had 2 patients and both had good outcome. While CPR was on, we thrombolized it. That's what he's trying to ask us.
Yes.
Again, I think you'll have to have a proven CPR, a proven PE. Other in out of hospital CPR.
No, only in hospital. Patients already in the hospital.
No, but out of hospital, you got a slightly better chance because a well patient out of hospital as an arrest is highly likely to be an MI or a PE, and both are likely to benefit from thrombolysis.
That is true.
So while in the hospital, the CPR will more likely be related to some underlying illness. So you need to be a little careful about just thrombolizing everyone.
Maybe a patient who is clinically stable and has sudden witnessed cardiac arrest.
Yeah,
Yeah, but that won't happen in a hospital, right? You won't be in the hospital if you were fine.
No.
They are for a surgery. They are for
a surgery, and post surgery within 12 hours had a sudden cardiac arrest and we thrombolize. That's what I'm trying to tell you.
Yeah, but
Not for the primary medical disease, Farad. Not for the primary medical disease, Then that was a lapse in the diagnosis. If the patient was there and they had an arrest, then
Recently, we had a patient, sir, who is a 28-year-old having suspected pelvic malignancy. So actually, he was undergone FNAC of that lesion. So he was there he was there in the ward. So before the diagnosis, suddenly he was stable and he collapsed. Unfortunately, we could not save him. We suspected the possibility of pulmonary embolism, massive pulmonary, because he was fine before that. So, but he did not give much time. So these type of instances do come.
No. So, Dr. Kaladhar, in that instance, if a young man non-diagnosed and had a CPR, I will bet more on eCPR rather than, thinking of doing thrombolysis or a vis-a-vis query P, massive P. eCPR gives a better outcome.
Yes.
If you have the facility, and I'm sure most of the hospitals who are doing ECMO can have the things ready within half an hour to 45 minutes.
okay, there are some more questions. Dose of alteplase in cardiac arrest, data supporting it. I'm not aware of any data, so basically.
There are no data. I think the dose will be the same, it will not change.
Okay. Should post-PT, should we accept a low PO2 compared to acceptable value, or any structural change in the lung? Is it expected? So, I mean, I think you can accept a low PO2 as long as it's, more than 60 and it's not, I mean, you'll have to go by the clinical context. In a chronic hypoxemia, you can accept it. In acute, you'd expect it to be at least above 60 PO2 or saturation 90 in a acute setting. How to manage for chronic post-PE on anticoagulant for 3 months admitted dyspnea? Again, pretty much the same as you'd manage any other dyspneic patient. You again look for a cause and depending on the cause, you'll do that. In a peri-arrest situation, is tenecteplase a better drug than alteplase as it can be given in a bolus? Again, I don't know the answer, but I'm assuming that in a peri, you're going to give both as a bolus.
Both as a bolus, yeah.
We also have a patient, TKR day 1 had cardiac arrest, recovered with alteplase, peri-arrest, his echo showed RVR. Yeah. Okay, so this is not very uncommon. And theoretically, post-op thrombolysis is contraindicated because of bleeding problems, but the exception to that is a cardiac arrest. Management of PE in pregnancy. I don't think it's particularly different from a non-pregnant, except that I don't think I do anything particularly different except keep a obstetrician involved and hope that you don't harm the fetus in the process of curing the patient. Anyone else has any answers to these questions?
No, I think I agree with you. Venkat, any answers?
No, I think they are.
Okay, post-thrombotic syndrome and reperfusion syndrome post-alteplase. I think these are two separate things. So any person who has a major shock, whether it's hypovolemic or cardiogenic or anything, and then you resuscitate them, they can go into what looks like a septic shock, which is because of a reperfusion injury. The management is pretty much the same as that of anyone with a vasodilated form of shock. The post-thrombotic syndrome. Sorry? And the post-thrombotic syndrome is another, at least I'm not sure what Santosh here wants, but the post-thrombotic syndrome normally refers to a painful leg because of venous abnormalities following a DVT. And frankly, there's not much you can do besides symptomatic treatment or refer to a vascular person to see if something can be done. It's not a good syndrome to have. But one thing should be clear that it's not an indication for very prolonged anticoagulants because the problem is a distortion of the architecture of the vein and not a persistent of thrombus.
And I think it's now a very rare phenomenon because diagnoses are very prompt. It used to happen just 5-6 years back. Diagnosis very prompt nowadays.
So any lights on eCPR in this context, as you rightly raised the issue?
I mean, see, Venkat, eCPR, see, the people who are from an ECMO team, they will always think about doing eCPR in such patients who are potentially reversible. See, these are all reversible patients. But only eCPR will benefit if you don't have malignancy underlying. As you said, there was a young man suspected to be malignancy. Nothing much we could have done. But eCPR for a patient who is actually having a reversible or a provoked cause, and you have ongoing need of surgery. So peri-surgery means if you have a cardiac surgeon and there is a contraindication for this anticoagulation, thrombolysis. So eCPR with surgery will be the choice for people where you are in a very highest resourceful area. Generally, it should not be the norm for P. A person coming with chest pain, obese patient, we don't know what happened, suddenly arrest in the ER. You can just put him on eCPR, and then while the eCPR is there, then you'll bide some time to, diagnose why the patient had an arrest in the ER. And generally, it will not be the case who is already admitted in the hospital, as Dr. Farad said.
Farad, sir, any comments on the partial thrombolysis which has been given as a part of making a biomarkers and other points taken into consideration, the burden of the thrombolysis without hemodynamic?
My personal view is there's see this I'm going to have to give a question answer which requires whenever we do medicine, we do medicine based on two things. Does it make sense, or we call it plausibility, and has it proven in trials to actually do what we think it does? So once we have data which shows that it works or doesn't work, we should be using it across the board. But more often than not, we don't have data which shows that it works, or we have observational data which is not really a form of proof. In that situation, I think you're entitled to try it. But I think you should try it with truthfulness to yourself and with truthfulness to the people, that we don't really know if this works, we'll try it. And the most important thing which I think you shouldn't do is fool yourself that if the patient got better, that your intervention worked. Okay, the patient could have got better for a lot of things. So I can't answer the question better than this. If you really read the data on PEs, it's quite sad how little is showing to improve clinical outcomes. And again, need to keep in mind, PEs generally occur in sick people. So they're more likely to die of the illness which precipitated the PE, rather than die of the PE itself. In many, the malignancies, cardiac failures, etc., etc. So it's the peri-op patients, the young patients, the ones who happen to have a thrombotic, prothrombotic congenital state where you can have very good long-term outcomes. Those are in day-to-day practice, especially in inpatient practice, much, much less common. You do see them every now and then outpatient, and you've got families, who have been following up for 10, 20 years with whatever factor latent deficiency or this or that. But that's a small subgroup for people like us who basically deal with inpatients and ICU patients. It's more common in outpatient practice. So to work up the patient for a cause of a P, the younger they are, the more you're going to look, and it's unprovoked. The more you're going to look for a congenital factor of some deficiency or some inflammatory condition like APLA. And as the patient gets older and older, the more you're going to look for some underlying malignancy or a new onset inflammatory system. This is, of course, I'm talking of in the context of unprovoked. So this patient, I would probably at some point get a PET scan. I'd have a talk with this patient and get a PET scan. If the PET scan is okay, try to optimize the background illness, keep the patient on anticoagulants for about 6 months, and then have a discussion about where we go further with this.
And many times the other problem comes in a situation, not just a massive embolus, when there is a maybe submassive, maybe segmental. The problem is these patients receive anticoagulation. The workup goes into delay, hypercoagulable workup, even in unprovoked situation.
It doesn't matter too much now, because the workup is really to tell you how long to give the anticoagulation. So whether you work up in the beginning or you work up afterwards, if you have a very strong risk factor, you'll put them on long-term treatment. If you have an absence of a risk factor, you'll stop them. So I am not too hung up about which time you do the workup, because the workup doesn't dictate your initial treatment. The workup dictates the duration of the treatment. So whether you do it earlier or later doesn't matter too much. And of course, the illness itself and the anticoagulation can change some of these markers.
Yeah. So initially you will start with anticoagulation. And when will you like to actually go for those workup? At what point of time? Because
normally when I'm planning to stop it.
Okay. Do you stop and then after certain duration you do it?
Again, yeah, again, you got to decide the risk. Most of these patients, they come to the outpatient and they're well and the CTPA is cleared, and I think you can aram say stop for a short time, do off all the tests, have another consultation and explain the pros and cons of staying off or starting, and explaining when to come back and so on. I can see sorry, I can see a hand raised in this thing.
Yeah,
How is it in the questions? Because I really would like to interact with you all, but I don't know how to do it because I seem to be locked out of you all.
No, I think the questions are finished actually, the 12 questions.
But I just now saw a hand raised.
Pawan, can we actually make them make them unmute or something? Those who raise
If anyone wants to ask a question, please feel free to ask.
Yeah. So anyone has any queries? Please raise your hands or put your queries.
Okay, I can see some another one. Does anticoagulant we use during the treatment lead to misinterpretation of the? Yeah, it could in certain. I mean, obviously, for factor V laden, which is a genetic test, it won't matter. But from something like antithrombin 3, protein C, protein S, which are actively involved, you can definitely get a non-baseline reading. Let's put it that way. What we want is to know what is the baseline, and in any illness in this thing, those factors are there appropriately react. So factor antithrombin 3, protein C, protein S, etc. It doesn't make sense to do it during the illness, because anyway you'll have to do it later to see what the baseline is.
So probably the rest we can do, as you said, the factor V.
So exactly. So if you're doing an immune marker, if you're doing a genetic marker, then it doesn't really matter. If you're looking for a malignancy, those kind of things doesn't matter. But if you're looking for something which is involved in the thrombotic pathway itself, it will automatically alter because of the disease or the treatment. So you need to do that later.
From diagnosis point of view, I think the role of D-dimer wasn't discussed.
Oh, good question.
Sindhu or Shashi, do you want to answer?
One of you all want to answer? What is the role of D-dimer?
D-dimer has negative predictive values, sir. It has more false positives. It can be raised even in other conditions like trauma or renal failure or ongoing infection. So,
as we learned in the COVID epidemic, so D-dimer is like CRP. Okay, just in the evolutionary pathway, the coagulation and inflammation were one pathway, and then later in evolution they separated out, but they are triggered by the same thing, and they untriggered and unbound by the same thing. So it can go up in any stress state, right? It's just that we were measuring it before COVID only in suspected Ps, but when you started measuring it in viral illnesses, nothing surprising that they went up along with the CRP and the LDH, and nothing surprising that they came down. So that's a good first answer. First part of the answer, it's got better negative value than positive value. But anything else you want to make it a little stronger than that?
Yes. In which category of patients you want to make that statement? Low risk, high risk?
And D-dimer values also alter during pregnancies, and in pregnancy there is a higher cutoff compared to a normal patient.
Yeah,
it's around above 1400 to range 14 to 1500 during first trimester, and up to 1700 during the second trimester, sir. And D-dimer, if the patient is having a clinical suspicion and whether to go for a CTPA or not, D-dimer having a clinical correlation with having a positive D-dimer value can help to decide whether to go for a scan or not. So that's one other use of it. And
not bad, but there's still one thing you've not said. So basically, a negative D-dimer is very useful in low probability for PE and moderate probability for PE. A negative D-dimer alone is not enough for a high probability PE. That's the answer I want. Okay.
Yes.
So don't close your eyes and say D-dimer is negative. It can't be a PE. It could still be a PE. And remember, D-dimer is a marker of active clotting. So PE could have occurred some time ago. The clotting could have stopped. So you have to just sort of put all this in your head when you interpret the PE. But a normal D-dimer in a low probability, for whatever reason, the commonest commonest way a thing becomes low probability is you find another cause, right? So you say, okay, I don't need to look at this thing. So negative D-dimer and high probability still warrants a workup, but otherwise a negative D-dimer and a low or moderate probability doesn't matter with it. Which score has been validated for PE risk in ICU patients? Which score has been validated for bleeding risk in ICU patients?
PE risk in modified.
Right. I'm asking in ICU patients. Okay.
Revised Geneva score, clinical probability.
No, so the answer is to date, there is not a single score which is valid, which is derived and validated in ICU patients. So we take it from another group of patients and then we apply it to ICU patients, which is in our view not a very smart thing to do. Okay, so my view is that you look for a thrombotic risk if they are unwell, and all our patients are unwell, ventilated, inotropes, renal failure, blah, blah, blah. So it's very few patients who are low risk for a PE in an ICU. Those who come for short-term observation, those who come for whatever, those are fine. But otherwise, almost everyone will have some risk factor. So those scores are not particularly useful for us. Similarly, there's no validated bleeding thing. These are all validated for people who might bleed in the community. So again, you just go by the standard coagulopathic features you see in any sick patient, the low platelets, the low this thing. So those would be patients you'd be careful about anticoagulating. And the other, you'll be very careful about obviously the next one is you're doing a procedure, so you want to be able to turn it off. And the third one is if the bleeding is in a high risk area. So if it's in the brain, on the spinal cord, or in the airway, then even a small bleed can be life threatening. So these are the situations where you'll be careful about bleeding, using anticoagulants and bleeding risk. So the point of this question was don't blindly use the scores which have been derived in cardiac failure patients, in post-op patients to our ICU patients. It hasn't not been done or not been validated.
Other markers, biomarkers, sir, NT-proBNP and troponin.
Yeah, for those who know the Costanera study, the first study looked at altiplase in high risk, and that high risk was defined by echo and by ECG, and that was labeled as a positive study, in my view, falsely labeled as a positive study, because a composite endpoint was positive. But all the major endpoints, the CPR, ventilation, inotropes, recurrence, all were the same. The only difference was that there was more rescue thrombolysis in those who didn't primarily get thrombolysis. In my view, that was a very, very poor composite endpoint. But be that as it may, it was labeled as a positive study. In my view, the strength of that particular study was it showed that the bleeding risk was similar in both the groups. So that study was based on echo and ECG. The second Costanera study, which used tenecteplase, was based on intermediate risk on biomarkers. So they couldn't define which patient would benefit from thrombolysis using ECG and echo. So they tried to define which patient would benefit from thrombolysis by using biomarkers. And if the biomarkers were raised, they were deemed as intermediate risk and they were given thrombolysis. Now, in that trial, there was a clear benefit in terms of inotropes. But in that trial, the bleeding risk was significantly higher. So we have one trial where the benefit was minimal and the bleeding risk was minimal, and we have another trial where the benefit was there, but the bleeding risk was there. And based on the trials, the current recommendations are don't use thrombolysis intermediate risk unless it's progressing to high risk. Okay, and just for the sake of completion, high risk is if in the, as you said, hypotension, but also CPR and also recurrent syncope or syncope. These three should be viewed as high risk. And if the ECG, echo, and biomarkers are up, in the absence of this, it should be viewed as intermediate risk. Some people use massive and submassive, and others use high risk and intermediate risk.
Manoj, any comments on your interventional radiologist coming into play and doing local thrombolysis, thrombectomies, thromboretractions?
No, I think we have very less people. We are blessed that we have less people entering into that territory, They definitely have as the ROTEM devices. There are devices which do this. But in our country, I think in our state, we have very less exposure. Theoretically, yes, they are the ones. These are the interventions which definitely will come into play for very high-risk patients who will be at high risk for bleeding. So these are the patients whom this therapy can be offered. That is my role play there.
Yeah. The role of local thrombolysis is unproven, but the theoretical advantage is the dose is much smaller. So I think once again, you have to individualize to a patient. The patient needs thrombolysis. You're really not very confident about, because the dose I think is 1/3 or quarter or even less than that. So once or twice we've done local thrombolysis. You can do it. I mean, the other advantage is you can leave the catheter and then take a shoot next day and actually see that it's gone. before you take the catheter out. So there are some advantages, but it should not be a standard option. Standard option is intravenous, full dose, and it's only this option is if you're really worried about a high dose and you think you can get away with a smaller dose.
Yeah,
But I think to answer your question, we should be involving our interventional radiologists more and more. I mean, the usual thing is the less we involve, the less we think about when we need them. We should involve them even if they don't end up doing something. We should have a team-like approach saying, listen, guys, keep yourselves alert. We might call you at any point of time. Please come and see this patient. So that it's not, called at the last minute.
There's a last question here. A patient with RT and sepsis with AKI, if D-dimer is high, 2D echo is suggestive of mild or right-sided dilated heart. How does one decide the role of CTPA? I think I'll answer in this way that mild dilatation of heart can be because of volume overload. I don't know whether the patient is on ventilator. How hemodynamic stable is the patient? The algorithm for need of CTPA, if the patient has a sudden deterioration and you see severe dilatation of right heart, it will be one of the indications to do a CTPA, irrespective of the kidney injury. But probably here the patient which you are trying to ask is already a septic patient with kidney injury. Even volume overload, patient on ventilator can have a mild right-sided heart dilatation.
There are a couple of questions before that. Is D-dimer a marker of fibrinolysis or clotting? Good
I think you have already answered it.
No. Is D-dimer a marker of fibrinolysis or versus clotting? So the earlier markers were we call FDPs and XDPs, and those were a marker of lysis. But D-dimer per se is a product of the last phase of clotting when the I can't remember.
You said active clotting.
Yeah. So D-dimer as against FDPs and XDPs is a marker of clotting. I think it's the polymerization, or I can't get the exact term, but there's a more fibrin monomer, fibrin polymer, and then fibrin polymer, something happens. And at that stage, a D-dimer is released. So D-dimer is an end product of the last stage of clotting, while the FDPs, XDPs, and etc. were a marker of thrombolysis. That means a breakdown of the clot. So that was that question. As discussed before, eCPR is not indicated in provoked PE. I'm not so sure about that. I mean, if a person has had a provoked PE after a DVT, I mean, after a fracture surgery, I don't see why you shouldn't do EEPs. I think eCPR and CPR is the same thing. The indication is reversibility. The more bad the prognosis is and the less you'll do anyway CPR, you'll put such a person as DNI, DNR, right?
Yeah.
But if you have everything is based on reversibility. The more reversible it is and the more available the eCPR is and the more affordable the patient is, the more you'll consider it, regardless of whether it's, provoked or not. What you want is there a good chance that this patient will get better and stay better? That would at least be the way I would answer this question.
Rather than provoked, maybe end stage diseases leading to PT, not.
Yeah, but that would be two all forms of CPR. You'd start counseling them that, listen, this is not the patient you want to do a terminal futile CPR. Let's make plan on good palliation.
Yeah.
Also, LASIX in severe RV dilatation, further preload, increase in the preload may further increase the RV dilatation and impinge on the left ventricle, further decrease LV output. Is that the substantial part for LASIX?
Again, if the LV is dysfunction and there's no, if the LV is being compromised, but there's no pulmonary edema, what are you going to gain?
Not pulmonary edema, sir. RV dilatation causing
shift to the LV. So what? If it shifts to the LV, what will happen? One of two things will happen. The cardiac output will fall or the pulmonary edema will happen, right? So if it will still be a standard indication of L. It's a good idea not to just keep treating images, but to sort of in the context of an ICU sick patient, as against someone who's got cardiac failure in the community. LASIX should be used in two and only two situations: pulmonary edema, severe oliguria. Okay, too many people are getting unnecessary LASIX all the time, and really you almost never need a LASIX strip. A LASIX strip has become to some degree a Pavlovian response. The output is low, chalo LASIX deo. And I hate it in my ICU. I want you to think before each dose of LASIX, because the low output is the kidney telling you that you're not doing a good job by perfusing the kidney. So you go back to say, why am I not perfusing the kidney? Now, once in a way, a person is stressed out, the ADH levels are very high as part of a stress syndrome. And there, the output is very low. And everything else is okay. And the BUN creatinine is not rising. There, giving a small dose is fine. But it's more like a test. If you give 5-10 milligrams and there's a huge output, you know that I don't have to worry about a hemodynamic problem. I'm not missing something here which is going to lead to renal failure. This is a stress response with excess ADH, which is making the less urine output. So you can use it in that context. But by and large, you should always try to treat the cause of the oliguria rather than to just give Lasix and hope for the best.
Yeah, in this situation, in our case, I think I totally agree with Farhad. RV dysfunction is not the criteria of Lasix. You should, in fact, augment the RV failure by using mechanical or chemical. So your mechanical devices are not proven. So here you should use the combination of with dobutamine. And if you see open heart surgeries or CTF surgeries, when you just open the heart, RV never contract, it just quivers. So by giving Lasix, you are not actually helping the right heart. As he rightly said, if it is pulmonary edema, you are always helping the left heart and oliguria. Lasix was not actually indicated.
Okay, there's another question. Any role of inodilator in PAH in acute PE? Again, our primary worry is that the patient is going to get hypotensive. So I'd be very careful about this. I mean, a low output without hypotension, that patient is generally going to get better with anticoagulation. It may take a few days, but that patient will get better. But choke circulation with hypotension is bad news. So this is, if you look at this, I mean, of course, there's a vasoconstrictive element in the lung, but if you look at it as a primary obstruction, then causing a vasodilator, what is going to kill the patient is our question. Severe hypotension, low cardiac output, or the next clot. That is the two things which are going to kill the patient if you leave aside the background disease. So we prevent the next clot by giving anticoagulation or maybe even thrombolysis. Thrombolysis may benefit by also decreasing the venous burden in the lower limb and therefore decreasing the chance of the next clot if you happen to give thrombolysis. You shouldn't be given for that, but if you happen to, and in certain very few cases, you might put in a IVC filter. So that will prevent that from the next thing. And then you just prevent hypotension and as the anticoagulation kicks in, the perfusion, cardiac output will get better, the perfusion will get better. And as you can see, this patient did very well primarily because the clot was dissolved and the choke circulation was opened up. So I hope that answers this question.
Thank you.
Yeah, I think.
So I think we had a very good discussion overall. So with this, I thank Dr. Farhad and Kapadia sir, Dr. Manoj Singh sir for giving their valuable time and sharing the academic experience on this platform. So I thank Dr. Kola Venkat sir, whose brainchild is the masterclass, because of which so many students are benefiting, and we are also learning day in and day out.
Farhad sir and Manoj sir, I think it's a privilege and honor to have both of you on board and having shared your knowledge and experience. It was actually a dynamic flow. To be honest, we have been listening to many, but again, listening to both of you, Farhad sir, the way you always been in the last 20 years I have seen, you take your flow as you practice, as happens at the bedside. Thank you, sir. And thank you, Dr. Manoj.
Thank you, Venkat. Thank you. Thank you. Thank you.
Dr. Sindhuja and Dr. Shashkiran, we thank you, both of you, to bringing out this case, and extensive discussion happened. So, and we thank all the participants taking out their valuable time and listened to the webinar. So with this, we will bring out.
Yeah, just one last comment. I don't know what the culture in your ICU is, but you should feel free to ask your consultant things you think are not appropriate, like Lasix and so on.
Yeah.
That's one of the advantages of teaching sessions.
Yeah, how many diseases are you treating today? You told it is P. Why are you increasing? You should be proactive. It's just
and one of the advantages of teaching session is that teachers also tend to be more receptive to questions. So one of the ways to decrease conflict in an ICU from different specialties to involve both the specialties in a teaching session.
Correct.
Because at that time your mind is open and you'll see both sides, and then the practices will become a little more streamlined.
True.
So try to prevent unnecessary treatments in the ICU just because you've done it in the past. I personally would not have used a bicarb drip in this patient. I definitely would not have used a Lasix infusion in the absence of severe oliguria.
And carbapenem as well.
Yeah, I can. That's right.
Thank you for your input, sir.
Thank you.
Theory translating into practical experience.
Okay, thank you very much.
Thank you.
Thank you. Bye-bye.